Good morning. With respect, we acknowledge the Nevada County campus of Sierra College as the traditional and unceded homelands of the Nisenan peoples. For countless generations, the Nisenan have carried out their responsibility as stewards of this place originally known as DASPA. Sierra College commits to an ongoing relationship with the Nevada City Rancheria Nisenan tribe and their future generations who are an integral part of the Sierra College community. Good morning. I'm Judy East, and I'm the chair of the Nevada County Council of Sierra College Foundation, and we are very happy to sponsor these community forums. We are a body that is devoted to the Nevada County campus in terms of fundraising and advisory council. We have put $20,000 each year into the campus, and that has been in the form of scholarships, art programs, lecture series, an emergency fund for students, the pantry, basic needs and food pantry, and as I said before, scholarships. We are in the process of reorganizing the council and are interested in anybody who'd be interested in being a board member. So after the meeting, if you might be interested in that, please let me know. This is today, next month, November is our last forum of this year. We take a break in December and we'll come back in January. And next month, we're going to be talking about the role of AI in our community. So today, if you came in the side door, please exit the lobby because we have a fabulous faculty art show in the lobby, and I'd love to have you see it. How many people have not been on the campus before? Oh, okay. Well, I invite you after the meeting to please go up to the campus and take a look around and see what your tax dollars have funded. Thank you. And Carol?
Yay, thank you very much. Good morning, everyone. You are in for some amazing conversation today because of three guests that we have sitting up there looking all full of themselves. Yeah. So someone asked me how I got this job. I was standing here, I think, last month, and here I am this month. So what today is about, something near and dear to my heart, and it's healthcare and rural healthcare. My background's in healthcare. In high school, I worked in healthcare. As an adult, I worked in healthcare. And I am passionate, just for those of you who may wonder, I am passionate about the care here in Nevada County. So the conversation is really about how do we sustain that with what's going on and the changes and all the things in our lives and the lives of people around us. How do we make sure that we continue to have the same level of excellence? So in order to make sure that, because I'm not the expert on that part, but these three wonderful people are. So I'm going to ask them if they'll take a minute and they would introduce themselves to you and what their affiliation is to healthcare here in our northern area, and then talk a little bit about how long they've done that. So I can talk with you. Yes, thank you, my friend.
Hello. All right. I'm Jennifer Malone, and I am the CEO of Western Sierra Medical Clinic, which is a federally qualified health center. I have been in healthcare for over 20 years, in safety net style clinics, except for when I was in the Air Force, and that was a little bit different. But I did work in the hospital.
Hi, good morning, everybody. I'm Scott Neely, and I'm the president and CEO of Sierra.
Dr. Neely,
What?
pretend like it's an ice cream cone.
Oh, yeah, okay. I want the great big one with the waffle thing and the sprinkles. I'm Scott Neely. I'm the CEO of Sierra Nevada Memorial Hospital. I've been a physician for 37 years, most of that actually actively practicing as a lung specialist and a critical care doctor, but I've been an administrator for about 13 years now in various roles, and I've been the president of Sierra Nevada for about 3.5 years.
Good morning, everyone. I'm Lisa Davies. I'm the CEO of Chappaday Indian Health. I've been in healthcare about 25 years now. I started actually here in Nevada County with the local independent physician organization back in the late 1990s. Joined Chappaday in 2002, and then I became Chappaday's CEO in 2010. So I've held that role for 15 years now. And we are a tribal health program. We focus on American Indians, but we also serve the larger community, low-income Medicare, Medi-Cal patients.
All right, so all of you have had some longevity with healthcare and business. So how about a conversation amongst the three of you? We can start down here and then come across what's changed or what looks different or what makes it easier or harder. Any conversations about what this looks like nowadays?
Yeah,
Yeah,
well,
you don't have that much time.
it is the only question we're going to ask today, I think, Carol. So, having been in healthcare 25 years, I guess what I would start with is, specifically in community health, it's been sort of a remarkable change. The Affordable Care Act was a really good thing for our community. It expanded Medi-Cal to so many community members who've been able to access care who simply weren't able to before. They didn't without coverage. So as a result, community clinics like Chappaday, and I know Jen would talk about this too, and Western Sierra, we've been able to expand services, we've been able to expand staffing. I think that's one of the things that isn't talked about a lot in community health, how much we contribute to the local economy. Chappaday alone, over the last 15 years, we've added about 200 jobs, over 80 jobs in Nevada County, and those are people shopping in our stores, going to our restaurants, bringing their families here to enjoy our region. But those employees have also allowed us to expand services. So outside of core medical, dental, behavioral health, we've been able to respond to the community need around substance use treatment. We know that Nevada County has a higher incidence of drug overdose than the state average. We've been able to add prenatal services, pharmacy services, care coordination services to help patients with social needs that contribute to health. The one thing I will say that's also changed, I think, in healthcare, and I think Dr. Neely can probably speak to this even better than I can, is just how hard it has become for the workforce. People enter healthcare largely because they're called to serve and to help others. It's a human-to-human business. But with that increase in demand and need, the pace of the work, the amount of documentation and paperwork, the emotional toll, all of that has increased. And so we've seen burnout for our employees increase as well over the years. And it's not because people care less, it's because they care so much, but they feel really stretched thin. So it's sort of the story of prosperity and pressure. So patients getting access to care, but strain on those people who are responsible for providing that care.
Dr. Neely, how about from your perspective?
Yeah, the way you answer this question is all about perspective, because we could literally just talk about this question for the next 2 hours. I'm going to sum it up very quickly from a very personal perspective. I think the first thing that I have experienced changing over the last 40 years or so has been a real strong shift towards safety and quality in the way we deliver care. That was just not a thing when I started medical school. We oftentimes assumed that harm events, medical errors were just sort of the cost of doing business. And we have really grown into the fact that almost all medical error and harm is avoidable, and that by practicing evidence-based medicine, we can really achieve tremendous improvements in the quality of the care that we deliver. That's something that we continue to really embrace and focus on. I think Lisa referred to something that I certainly see. It's just gotten harder it's become a lot more technologically demanding. And as it has become more technologically demanding, it's also become a lot more expensive. And we have a growing mismatch between the various sources of revenue and the amount of revenue that's available for healthcare organizations and the cost of providing care. And that's because the technology in healthcare, it's been very interesting. In many fields, technology has reduced the cost of doing business. In healthcare, it has increased the cost of doing business. And people are demanding more technologically advanced approaches to care, whether that's medication or procedural or whatever. You know, we're going to make the entry into robotically delivered surgery at Sierra Nevada within the next year. That's a multi-million-dollar investment. And some of that's actually better care, but a lot of it's also being driven by folks just saying, well, I want a laser or I want a robot, not necessarily knowing whether that's going to give them a better result or not. But as things have become a lot more expensive, I think that's driven something else in healthcare, which kind of brings that area of it's getting harder and more expensive, and it's also getting safer and higher quality. There's an increasingly important conversation about, well, what does it take to keep people well as opposed to deliver sick care? In the hospital, we're primarily delivering sick care. We're taking care of things after it's already broken. And that's expensive. And what's the alternative? And the alternative is, well, how do we help people stay well and maybe avoid the need for, rescue care, whether that's procedural or whether it's chemotherapy or whatever. And so I think we sometimes hear about value-based care. That's sort of the payer saying, well, what are we getting for our money anyway? Our people aren't even healthy. So that's an increasingly important movement as we recognize that being healthy and being well does not necessarily equate simply to having a really good healthcare delivery system focusing on sick care. So I think that's an important thing that's happening, and it's certainly something that we're focusing on as well. I'm gonna clam up here because
I'm gonna say
I might just take the lid off of another. You go.
You're good. Yes, to all of that. It is very good. So I'll talk about what's changed, and it's really near and dear to my heart, and that's access to care. You can remember maybe way back when you had a small town doc that you went to and they did everything. And it was very taxing on those doctors to do everything. And since I've been in healthcare, the clinic movement, the community health, Indian health movement, hospital clinics, foundations have all been able to really realize that access to care is so vitally important. And so in my time, we at Western Sierra, we have been able to now serve 4,000 square miles of service area by adding smaller sites and being able to ensure through telehealth, through urgent care services that we're allowed to have now, to be able to have immediate access and long-term care for chronic care type services. That is so unbelievable to see the difference between then and now, that the kind of care that you're able to get. So I will say that puts another layer on quality, because the worst quality is no access at all. And so we are really, really committed as a team to make sure that there's access for all of you and try to sustain that for as long as we can, even though we have challenges financially and regulatorily coming about. I made it up, and it does work. If you know what it means, it works. So, so the other thing I wanted to talk about is partnerships. Because we came out of the pandemic crisis and now we're coming into a potential fiscal crisis with healthcare, we've been able to form partnerships. The three of us have become huge partners within Nevada County with the same mindset, access and quality care. So that has been something that has changed throughout the years as well.
So with all of that, and thank you so much, it just so speaks to me. Would you agree? It's like way different. I started out in healthcare way back in the 70s, and it didn't look like anything we're doing now. And so how wonderful for us to have these three experts here in our community who get it, who actually know what we need to keep going. So my question is, how do we do that? I mean, you just said it costs more. And, you know, how do we make sure that we meet the needs of our community? Because personally, as someone who loves rural care, just by virtue of the lifestyle of my family, we have spent over the last couple years many, many days in the local hospital. And so the reality is, when you think about it, if we go to any of the services here, it takes away from what? Some of the stress of that. But I will tell you, 18 days of driving every day back and forth was pretty hard. But to know that the support was here when we needed it for the hospital up here. So thank you for all of you who are doing rural healthcare. We really appreciate it. Don't you agree? Yes. All right, so my next question is, they're gonna get harder. Those are so easy. So this one was given to me, and I think it's interesting. Explain how rural healthcare is being affected differently than bigger urban hospitals and clinics. Anybody want to take that one on? Silence in the crowd. Okay.
There's one that's really obvious to all of us. When money gets tight and you have grants or you have funding, the funding is going to go to the place that impacts the most amount of people. You know, the bigger bang for your buck kind of situation. So rural, we have to come together. And like, say, for example, that grant's Mountain Lion, we have to come together and look bigger than we really are so that we can get that grant funding coming to us. And that's just one of the problems with being rural. We don't have the voice and we don't have the volume.
Lisa? Okay.
I'm going to talk about a couple of things that I think are different about rural healthcare. The funding picture is very complex. There are actually benefits and disadvantages to being rural right now. And I don't think that's the overwhelming challenge for us or the overwhelming difference. I'd say, you know, two fundamental things. First is on the demand side. Rural populations tend to be less affluent, poorer. They have higher incidences of certain types of medical problems. And so the medical challenges are different because there is, on average, there's more smoking, there's more obesity, there's more diabetes. And so the medical problems that we deal with are a little bit different from that which we see in urban populations. The fact that rural populations tend to be, on average, a little bit older also changes the situation. And something that Jennifer referred to, access, is a huge issue in rural communities, and in a very different way. We have to worry about how we serve folks who live on the ridge who do not have transportation. And we think about that, and we design processes and systems to try to support those folks. So the demand side of rural healthcare is very, very different. On the delivery side, Lisa mentioned workforce. Workforce is really challenging to manage in rural healthcare. Subspecialty care, for example, has been an issue that's popped up numerous times in the last few years here in Nevada County because specialists increasingly want to basically set up in specialized delivery centers and have lots and lots of patients come to them. That model doesn't work very well in sparsely populated rural counties. And that's why we don't have neurology, and that's why we don't have urology, and why some other specialties are hard to actually keep up here. Generally speaking, more people want to live in urban areas than rural areas, even though we are pretty good at, finding that diamond in the rough who actually really wants to live in a rural area and to serve a population in a rural area. But it's really hard to find in terms of both licensed employees, therapists, technicians, nurses, as well as physicians. So it's a very different environment to work in. I've worked in both. There's tremendous rewards in working in rural healthcare that you don't really experience in an urban area where you really don't know, where you don't meet your patients at SPD. So there's some wonderful differences that are very beneficial and increase the fulfillment of doing this work, but there are significant differences that result in challenges.
Dr. Neely just made me remember I think most of you know that we participate in a residency program, a rural residency program with the hospital, which is wonderful. We have 6 residents so far. We're interviewing our 4th class right now, our students for our 4th class right now. And last week when we were doing interviews, some of our providers were asking the residents about how they would feel if they were at a baseball game in the community and a patient came up to them, or if they're at the grocery store and the patient came up to them, because that is a real thing that happens in our community. And our providers who work up here, they thrive on that. They actually love that. So important piece of rural health. That longitudinal sort of relationship in primary care is really important. And that's something I think even more so in a rural setting where generations tend to live and come to the same providers. I guess the only other thing I would add to what Jennifer and Dr. Neely talked about was kind of echoing back to what Jen said earlier about the importance of partnership. Our community clinics play a really important role of helping manage what actually goes to the hospital. And so we are there to take care of folks, help prevent disease, help keep them well. When they do have a chronic condition that's somehow exacerbated, to see if we can help manage that before they need to go to more expensive care, before they need to go through the ED to get care. And so we take that very seriously. And we've had to get creative about some of the ways we provide care. Jen even mentioned this earlier. Telehealth is something we really have come to rely on, especially for things like psychiatry and mental health. That's a growing need in our community. And we've also started bringing specialty services in. Specialty services are limited in our community. Medi-Cal, for those of you who don't know, and I think it ranks 46th in all the states in terms of reimbursement. For a lot of private providers, there's just no margin in it. So it's not that they don't want to, it's just that they lose money when they provide that care. So if we can create partnerships with those providers, bring them into our clinics, then we can make that care more accessible to our patients. And I think that's something that's sort of unique in a rural setting that maybe you don't see so much in an urban setting.
May I add one onto that? It may be uncomfortable to bring up HR1, but when you're looking at how to sustain, and it's going to be relevant to what Lisa just said, Medi-Cal income is really important for clinics in the hospital. It is a revenue stream that comes from outside our county into our county. And with HR1, what we're going to be seeing is our Medi-Cal population being very, very challenged with work requirements and and having to re-enroll in Medi-Cal every 6 months. That is going to be very burdensome for our community, for our neighbors, and for our friends. And so how can we help sustain and keep our healthcare systems going? It is to really come together and know that we need to help our communities to ensure the work requirements and the enrollment and our friends and our neighbors get the support that they need to be able to hold on to their extremely important health care benefits. It's not only important for their health, but it's also important for our community's financial sustainability. And it will be very devastating for us to see that go away.
All right, I'm going to ask a question not for the audience, because I'm sure you're all smart enough to know what HR 1 stands for, but for your facilitator, that'd be me. Can you give me a description of what that is? I mean, obviously, it's
It's the big, beautiful bill.
Oh, it's, okay, well, there you go. All
So-
right.
So very, very succinctly, I think this is important for people to understand because a lot of folks have kind of focused on the healthcare impact of HR 1, which is significant, but it wasn't a healthcare bill. Okay? It was a tax cut. And some of the politicians whose votes were needed to pass that tax cut said, we have to pay for this tax cut somehow. And the only big juicy target that was there to pay for the tax cut was Medicaid. And, you know, there were some other things that went away. You're not going to get, you know, nice benefits from purchasing renewable energy resources for your home and your automobile and so forth. But the big impact in terms of what was legislated to pay for that tax cut were cuts in health care for people who already have issues with health care access. So,
I think what I would add to that is it was sort of a savvy sort of side entrance into this. As Jen mentioned about work requirements, there's these community engagement requirements that people have to meet to maintain eligibility for Medi-Cal or Medicaid across the United States. One of them is you have to work. And so there's this assumption that people on Medicaid don't work. And the truth is nearly 70% of people who access that benefit do work either full-time or part-time jobs. They work low-wage jobs primarily, and so they're earning less than the federal poverty level. So for an individual, it's about $16,000 a year. For a family of four, it's $32,000 a year. And then the other 30% largely are students or caregivers or disabled, and they can't work, and they'll still be eligible for Medicaid. What they'll have to do now, though, is basically the equivalent of filing our taxes two times a year. They're going to have to pull together all the paperwork required to prove that they meet these different standards to be eligible. So it's not that they aren't eligible, it's just they're now going to have to navigate new layers of government red tape that don't exist right now.
that's a really good point because this is almost, these work requirements, this is almost an impossible bureaucratic task to actually manage that program. And what happens is people just get kicked off the rolls.
Excuse me, I guess I ought to use the mic. Huh? So with those thoughts in mind, what are you as organizations obviously working very, very hard to come up with some magic to have it level out and be a little easier for all of us. But is there programs in place or thoughts of what you can be doing to actually make sure that rural healthcare stays rural?
Well, the four meetings that Lisa and I did yesterday
Yes.
on this exact, if you'd want to go ahead and shed some light on who's going to be helping with all of this. Okay. So our health center, we are going to be hiring community health workers. We're going to be trying to partner. We're in 4 counties, so we're going to have to be partnering with 4 counties to make sure that all of our patients get to maintain their level of care. But We're doing a lot internally because we don't want to wait because that white horse may not arrive. So we all know that we're going to have to take responsibility for our patients, and they're going to have to take responsibility for themselves. And we'll work with our community partners because this community has a big heart and people are going to step up. But we can't assume that there's going to be somebody to come rescue us to help these patients do that. And I know that's not what anybody wants to hear, and hopefully I'm wrong, but we can't pretend that that's not a possibility.
Yeah, I mean, this is the conversation Jen and I are having. We both are going to be expanding our support staff to help patients navigate these new regulations and figure out how to fill out forms and deal with the documentation requirements. The issue is that we're also expecting decreased revenue. As people fall off Medi-Cal, we will see less reimbursement. At the same time, we're going to be investing in an infrastructure of more administrative support. And that means that dollars that, could have gone to new doctors, new dentists, new services, new education that will improve outcomes for patients. Instead, those are going to be going to people that help our patients fill out forms. So it's not super fulfilling for people who work in healthcare, but it's the reality. And as Jen said, right now, there is no additional funding. I mean, the clinics, the hospital, the county, we are not going to be able to do this alone, but we're going to have to share that burden along with our other community partners who help this same population in the schools.
I would say that we have a slightly different approach. It's sort of all of that. And, the hospital is here to serve absolutely every individual in the county. We don't have a specialty focus on Medi-Cal patients or Medicare patients or commercially funded patients. And, our mission is basically to survive. It's kind of an interesting thing when you think about it because the government doesn't expect any other business to provide them with products or services at below cost, but they actually legislate that healthcare organizations must provide services at below the cost of delivering those services. That's something that voters can do something about, but so far there doesn't seem to be any inclination in that direction. Now, to get to the answer, I think that the principal focus that we're taking at the hospital is that we have to compete. We have to run it like a business, and we have to, serve in every individual who comes to us in need. But we also have to provide an excellent service because we actually need the people who live in Western Nevada County to choose us and to look at us as a destination where they want to go, not just someplace where they have to go because there's some sort of an emergency and there's not enough time to get to Sutter Roseville. So our focus has been and is more than anything else on really providing an exceptional service to everyone who needs us so that they know that when they need health care, when they need surgery, when they need treatment for cancer or some other problem, that we're the first choice. And that means recruiting more primary care because primary care tends to be one of our front doors. That means making every service that we do at the hospital an exceptional experience so that people say, yeah, that's my hospital, that's where I go. And it means continuing to advance the sophistication and the quality of our service. So I mentioned that we will be starting a robotic surgery program. We have just learned that we've signed a new surgeon, a robotically trained surgeon who's exceptionally well trained and regarded and is going to be relocating here from San Diego. We will be welcoming multiple new primary care docs to our practices up here over the next year. We're just going to fight really hard to compete and make the services that we provide exceptional, and really try to convince people to stay here. There's a very good analogy. If you don't frequent our local businesses, you're going to end up with Walmart and Target and nothing else. Okay? And the same thing goes for healthcare. So we're working to make sure that we're providing the best care that people can get, and we're going to work to compete and stay in the game.
I think the other thing I'd say about all three of us is that all three organizations, are deeply committed to their workforce and making the work environment a place where people want to be and want to stay. We want longevity, we want retention, we want to be competitive in terms of workforce as well. And all three of us, I think it deserves to be celebrated here. All of us are or are becoming learning organizations. We are welcoming students into our facilities, either through the residency program or through relationships with UC Davis, with rural medical students and tribal medical students who want to work in rural settings, with nursing students, nurse practitioners, dental assistants. We want people to experience what rural health is and the beauty of what we do, so that it's not just now, but we're building for the future. And so I think that's a really important point to make.
All right. So my thought was, so we've been talking a whole long bit of time here about what you all can do. So I guess the question should be, what can we who stand here and sit here and go, I love my hospital. I don't want it to go away. I love my doctors. I like what's going on. I like the feedback I get. So how do we help? We don't have any money, just so you know. I'm kidding.
I've kind of already answered that question to a certain extent, Carol, but, we're preaching to the choir here. I've got my foundation here. I've got my board members here. I've got the Economic Resource Council here. So I've got all my buddies are here already. And you guys, right? And so this group actually already knows we need to support philanthropy, and we have phenomenal philanthropy support sitting in this room right now, probably for all three of our organizations. We're going to be able to start that robotic surgery program because of philanthropy. We're going to be able to reinvest in having a really sophisticated, completely integrated cancer center because of philanthropy. So that is a huge part of what enables us to sort of set ourselves apart in terms of having modern, state-of-the-art facilities, and getting our folks to stay here for their care, to utilize it. We all three, we work together to understand what have we got to do to provide the care that's needed so people can stay here, whether that's maternity services or surgical services, cancer care. Jennifer brought up access to begin with, but that is essentially what we do all day long. And it's one of the reasons I think that we work so much together, because we all have a commitment to making sure that people who live here in this county can access the care that they need. We need folks to take advantage of that, and to support our organizations.
Really fast, I just want to, you talked about maternity care, and it's a perfect example of the three of us, and by us, our organizations working together. Dr. Neely and Lisa, they have the residency program for FPOBs. We have, at Western Sierra, we have OBs, midwives, and FPOBs. We are going to be, at the end of the year, we'll be well over 300 babies that Western Sierra delivered at the hospital through being able to work together so that we as a community didn't have to worry about OB services maybe going away and working as partners. And so that is what we're going to have to do to sustain all of us working together, and you as the community telling us what you need. The reason we knew this is the community would be like, hey, we need to, where do we deliver our babies? What do we do? Oh, at our hospital, it's amazing. Our birthing center is fantastic. Come on over here, we have a midwife. It's been a beautiful partnership with the community being part of that. So how you can help us, tell us what you need. You needed cardiologists, we got it. We got cardiology services. That's what we need, is your voices.
I'm going to hit back to HR1 and something I said earlier about the clinics, the hospital, the county not being able to do this alone. As people start facing these new requirements, one of the beautiful things about our county is we do have just this network of wonderful nonprofit organizations and schools and other trusted institutions that can work together. All of us are going to need to help Medi-Cal beneficiaries, community members, work through those requirements, understand what they are, help fill out forms, provide internet access to the people who don't have it, direct people to the community partners that can help with those things if they aren't the right organization. The second thing I think is for those of you who know people with Medi-Cal and those who have Medi-Cal, is just take some time to be informed. Make sure your contact information is up to date with your health plan, with the county. Make sure you know your renewal date. Make sure you are paying attention to the mail. That's how you're going to be contacted about updates for timing of what you're going to need to do. And then if you have questions, go to Western Sierra or Chapaday or the county and get those questions answered. It's going to be a lot easier to maintain coverage than it is to recapture coverage after it's lapsed.
Doctor, did you have something you'd like to add to that? I guess not. All right, so we have just a few minutes. So if you want to raise your hands and ask questions, you're going to need to shout out because I am not going to run around with this microphone. So you have to be loud. So let's start over here, right there, next to Karen.
Hey, thanks very much. I particularly appreciated your preparing for this perfect storm that's coming our way and is already here. On the Covered California front, every day I'm hearing from people whose premiums starting next month or in January are doubling and tripling, and they're just going to drop out of the healthcare system completely. How is that being looked at as you gear up, not just for Medi-Cal, but the rest of the folks here who aren't as fortunate to me to be on Medicare, which I'm hearing is also at risk very soon?
I'm going to start with Covered California. That's mostly what we would call commercial insurance. It tends to be very high deductible commercial insurance, so it's kind of disaster only for more people. What's happening as a result of both what we've talked about for Medi-Cal, which is people being forced off the rolls, the same thing is going to happen with the Covered California plan, which in terms of folks who have access problems for healthcare, that's kind of the next group up. These are the folks who are actually paying for their own health insurance policies because they're self-employed, because they're sort of underemployed, et cetera. And they're going to lose healthcare coverage, or they're not going to be able to afford healthcare coverage. So the percentage of folks who have no healthcare insurance is going to rise. And that's something that is pretty much unavoidable. It's kind of going back to pre-Affordable Care Act. I don't know if the numbers are going to be comparable, but you know, there used to be millions of Americans who had no health insurance whatsoever. There still are, but there are a lot fewer than there were before the Affordable Care Act. We're rolling back essentially the protections of the Affordable Care Act, and there are going to be a lot more people who are uninsured. Now, that is going to cause access problems for those folks. They're not going to be able to see a doctor and a physician in a doctor's office or in a clinic, and so they will be lacking that that outpatient lower acuity care, which is really important. We've seen a decrease in mortality rates for certain types of conditions, which is directly attributable to those folks having access to outpatient health care. And that's going to be lost. Now, they're still going to come to the emergency department, and our organization, both because of our mission and our ethics, but also because of legal requirements, we will still be taking care of them in the emergency department. We will still be stabilizing them in the hospital, and so we're going to be doing even more care that we don't get reimbursed for. And this is going to be a financial burden for healthcare organizations of all shapes and sizes, but hospital emergency departments and acute care organizations are going to really feel the brunt of this. It's going to be very challenging for organizations like ours to maintain the level of service that people want, and to keep our emergency departments functioning in a level where people can really expect to have an unencumbered bed, to have the attention of an emergency room physician and other staff. We're already seeing a lot of overburdening of emergency services in the United States. This is going to make it worse.
Okay, another question up front here.
I have a question about telehealth. So my husband has congestive heart failure, and he is the patient of a physician in Sacramento, and they have a telehealth conference about every quarter. He also has a cardiologist who comes up here. And I guess it was just last week, he had an appointment with this particular doctor. And before he meets with the doctor on telehealth, he has various blood tests and things up here, and that doctor has all that information. So there's nothing to be gained by a face-to-face discussion. He's not examining his body or anything. So about a week and a half before this appointment, he got a call that said he can't do the telehealth anymore. You'll have to drive to Sacramento. So my husband said, well, just for the appointment, what would it cost if I just paid for it out of my own pocket? I'm thinking it's probably at most, because it's a 15-minute conference, probably at most isn't more than $200 or $250. And the answer was, well, we don't have an answer for that. You can't do that. So we had to drive to Sacramento, which took most of the, getting there back. The whole thing. So
I do have an answer for that. Yeah, telehealth got back to the retro pre-COVID time for Medicare, and basically because the budget hasn't been passed, they did not extend the special exceptions for telehealth for Medicare patients. That we don't know what's going to happen after the budget is passed, if they're going to go back. But right now, it's pre-COVID telehealth Medicare rules, which means that it's you can't do it the way that you have been able to enjoy it. It may change back. Medi-Cal still has the same rules because the state has passed the telehealth payment rules. And I don't know if they're going to pass it or extend the exceptions for telehealth or not. I don't know.
I think this is what Jennifer already said, but just to be very clear, they canceled the funding for telehealth. Yeah.
So neither my husband nor the doctor spent their time complaining about that, but they did each make a comment. And the doctor, we kind of all came to the conclusion, like, it costs more. It doesn't benefit anyone. The doctor wasn't benefited. The patient wasn't benefited, the hospital wasn't, nobody got any benefit out of this face-to-face.
It doesn't always make sense. I know it doesn't always make sense. It's just rules. Yeah. Is it okay if I answer something of your access and losing the exchange program? The counties, and I don't know which counties are going to be able to step up somewhat for CMSP. So there's going to be some county money, perhaps. I don't know the acronym, CMSP. It was before there was Medicaid expansion. The county had a payment system for a safety net for those patients that are going to be losing it because of the patients that you were talking about. Do you know what CMSP, the acronym is? It's been so long. It's been like 5 years. I don't remember what the
It's
acronym.
County Medical Services Program.
That's it, County Medical Services Program. The other, she's so smart. And the other thing to know that having a safety net clinic, we do not turn patients away based on their ability to pay. So we may not have room because we're full, but you still can come to our urgent care at any time. We do not turn patients away based on their ability to pay. Ever. We have a sliding fee scale. If you're unhoused, you don't pay at all. We are about access, and you come to our urgent care when we get enough space and more providers. You can become a patient. I am so committed to access that I don't know what else to say about that, but there are going to be some ways. It's just not going to look the same as it does now.
The only other thing I would mention is you asked about Medicare as well. That's still a little bit unknown. There is something in federal law that requires automatic cuts to Medicare if the deficit reaches a certain level. But the Congress has historically punted that down the road, so that has never taken effect. It's been in law for a long time. So there's this thought that that will also continue, but it's a crapshoot right now for sure. The second thing, though, I think something Dr. Neely said about is with Medicare. So folks may maintain their Medicare, but if we lose funding in the community and we have to reduce services in the community, that's going to affect everybody. That will affect uninsured, commercially insured, Medi-Cal, and Medicare, simply because we may not have the level of services that we presently do. So,
How about here? You're close. Okay.
Thank you. So I have a question about the costs. There was an interesting table in the newspaper that showed the cost of people who have insurance through their job, people who are getting, they're being subsidized through the Affordable Care Act and so on. And you made the point, it's really expensive. Are there any places that some savings can be achieved?
Nobody picked up a mic. Oh, there you go.
So, a couple of numbers. We have a number called net patient revenue. Okay, that's what we get reimbursed for the care we provide by these different payers that you mentioned. Our response to that would be, we've been working to cut costs for many years now, and we feel like we have a relatively lean provider system at the hospital. I will tell you that nearly 60% of our net patient revenue goes to salaries for our employees, salaries and benefits. If you talk to other business owners, they would tell you that is a really, really high percentage of your net revenue to be paying out for salaries. So we work really hard to be a good employer and to provide a great place for our people to work, but it's extraordinarily expensive. And we aren't going to get most of our employees are represented by either the California Nurses Association or the Teamsters. They're not really in line with giving us a break on salaries. The next biggest expense we have is pharmaceuticals, and the market is not heading towards giving us a break on those things either. So it's a it's a very, very difficult cost model to bend. And the short answer to your question is probably not much room there. Supply and demand economics, it actually does work. And it'll be interesting to see what happens as we continue to get squeezed. Just in terms of that cost model, let me tell you that we approved our community benefit report yesterday at our hospital board meeting. And what we heard is that one of the benefits that the hospital is providing the community right now is $23 million a year, which is the delta between what it costs us to care for Medicare patients and what we get reimbursed for those patients. So it's an incredibly difficult economic model, and we don't know if there's much more room to squeeze on the cost side.
I think the big pie in the sky dream in terms of changing the cost of care is you think about literally 5% of the population costs about 80% of, it takes about 80% of the care. And so in the big dream, it's investing more in primary care and preventive care, which is exactly sort of what these changes at the federal level are going to harm, because they're going to take away that access.
But I want to put a plug in there because in terms of helping people, that 80-20 relationship that you're talking about, in terms of helping people to essentially live healthier lives and to live longer and to live healthier, there's a lot that we can do outside of the medical system. The traditional medical system really is responsible for only about 20% of people's true health outcomes. And that's why we're standing up HealthSpan in Nevada County, because we know that the big opportunity is in helping people to be healthier, not in spending more on acute care. That's what we spend most of our money on. We should be investing in helping people to live healthier lives.
All right, we are almost at the end of our program. I'm going to give our wonderful, wonderful experts here today. How about a round of applause for sharing with us? And were they your closing moments, or would you like a closing moment? Because we have 3 minutes that you each get a minute.
I just want to thank everybody for allowing us to take care of you. Thank you very much.
We feel a great deal of gratitude, and really that it is a privilege to work here. I think that with all of the challenges that are inherent in rural health, there is a tremendous energy, a tremendous amount of benefit that arises from community, from the fact that we collaborate, partner, work together, and that we have this incredible community that we know has our back and really has the interest of everyone we serve at heart in supporting our capabilities to provide care to people.
I just want to thank you all and thank folks for trusting Chapaday. It's a very reciprocal relationship. You take care of us, we take care of you. That's how that works. I also just want to thank Dr. Neely and Jen, your partnership, getting to work with you two. You aggravate the heck out of me sometimes. And I'm sure people in the audience can relate who know them. But I also feel honored and feel really lucky to get to work with the two of you and your organizations. It's a very good partnership. And Carol, you did a great job for us. Thank you.
Thank you. My pleasure, because we need to keep our hospitals and our outreach peoples and all of that so that we can continue to be one of the most beautiful counties in the world, I think. So a big thank you to all of you. I did not ask you ahead of time. Are you, three of you, open to some chatting? Because I am going to close it off, but can you hang out down here? And all right.
That's so cute. Am I open to chatting? That's so
Did they just give you a hard time again? not fair. All right, how about again, one big round of applause. Thank you for including me. Healthcare has been a part of my life since birth, to be quite truthful, and but this was wonderful. So thank you so much for coming and supporting our fair.
That was really good. You harmonized. That's exactly it.